This week on the BackTable Podcast.
I think that you shouldn't underestimate the patient with fecal incontinence for sacral neuromodulation. When I started my practice here and in Tampa, I would say the number one indication that I was doing it for was fecal incontinence, simply because I query my patients for fecal incontinence. It's part of my talk track at this point. So, everybody gets asked if they have fecal incontinence. And not only does it work very well, but they are very grateful patients. And those are some of the happiest patients that I have in my clinic. Because if you go from having fecal incontinence to no fecal incontinence, that's a real game changer in your quality of life, right?
Hello everyone, and welcome back to BackTable Urology Podcast, your source for all things urology. You can find all previous episodes of our podcast on iTunes, Spotify, and at backtable.com. This is Jose Oche Silva as your host this week, and we have Danny Hoffman. Danny is a female urologist in the Orlando area. We went to residency together down in Puerto Rico. After that, Danny went to do his fellowship in female urology with Dr. Victor Nitti in New York. And then afterward, he went into academics. So, Danny, welcome to BackTable.
Thank you for having me, Oche. It's a real pleasure.
So Danny went to academics. He was a couple of years there, and now he's in our group in Advent Health, Central Florida area. So, Danny, let's talk first about why academics. Why after being in the fellowship with Dr. Nitti, you went into academics? What was it? Place? I mean, you went to Tampa. Tell us about that process.
So, when you go into that sort of fellowship or that sort of academic fellowship, there's certainly a pressure. Maybe pressure is not the right word, or expectation is not the right word, but there's certainly an inclination to go into academic medicine. And when you're interviewing for jobs, Dr. Nitti's always telling you, well, I've got this guy at the University of Miami that wants to talk. I've got this guy at Mass General that wants to talk. I've got this, so, most of the job interviews that land your way when you're graduating from fellowship tend to be in academic institutions. And I just had the fortunate situation where I had an opportunity at the University of South Florida in Tampa. And I have some family in Tampa. So it kind of was a good fit for me. And that's what took me to Tampa. I mean, you know me. My career's basically been a story of being at the right place at the right time.
Yeah.
And I've been very fortunate so far. And I think it was just one of those things that it sort of fell in my lap, if you will. And I had it was a great experience at the University of South Florida. Dr. Rafael Carrion is the chairman there now. He's very well known in sexual medicine, and my experience was overwhelmingly positive there.
Definitely. I mean, Tampa, great weather, great beaches, great food.
Great city. Yeah, absolutely.
Great staff there at USF. So definitely you couldn't go wrong with that. But academics was not for you, I guess. You wanted something more.
Well, it was a matter of priorities for me, right? When I went into academic medicine or made the decision to go into academic medicine, I had one child and a wife that worked full time. Now I have 3 kids and a stay-at-home mom, so my priorities have shifted a little bit. So, while the quality of life is certainly good in academic medicine, it was a decision that I had to make personally for myself and my family, right?
Definitely, and right now, I mean, you're doing great here. So that no question about that part.
No, it's been a great experience.
So let's talk about, I mean, in terms of the practice per se, how was your practice in Tampa compared to what you're doing now?
So, in Tampa, in the academic setting, you really do have the benefit of being able to pick and choose what you want to see, right? So there, my practice setup was basically 70% voiding dysfunction, neurourology, female urology. I don't just see women. I do voiding dysfunction in men as well. So, guys with BPH, incontinence, things like that. We did a lot of sphincter work with my fellowship. So anything that had to do with neurourology or MS, Parkinson's, stroke, I would say it was like 70% voiding dysfunction, female urology, 30% general urology, like stones. You can't get around that, right? And I love doing stones. I don't think I would ever stop doing stones. And, just general lumps and bumps that you get along the way. I think it's shifted a little bit.
Did they tell you, hey, you need to do a little bit of urology, or it was just part of what you wanted?
No, this is part of what I wanted, right?
Okay,
So for me to keep my fellowship certification, my practice actually has to be 50% female urology, right?
Okay.
So I would say at this point, it's like, it's shifted a little bit. It's like 60-40 female urology to general urology. But just happy to be busy and doing the good work that I do. But I think that certainly now that I'm almost a year here in Central Florida, I've definitely seen the shift in terms of seeing more complex voiding dysfunction. I'm seeing more consults for neurogenic bladder, complex incontinence patients, refractory, failed slings, failed first, second line therapies for OAB. So I'm very happy with that.
Yeah, and definitely within our group, we have a lot of guys that do oncology. So not enough that do what you do, and you came in at the right time, and everybody's sending patients your way.
And I'm very fortunate in my practice setup where both my partners are oncologists, and I have zero interest in doing oncology. They have zero interest in doing voiding dysfunction. So we play very well together and we refer each other patients, and it just works very well for us.
So yeah, and definitely, even though I do some voiding dysfunction, definitely the complex cases I'm sending your way.
Thank you for thinking of me.
Yeah. So Danny, so let's talk about what you do. I mean, voiding dysfunction, and but specifically, I want to talk about Botox and versus neurostimulators for that overactive bladder, or for some frequency, urgency, things like that. Are you doing Botox? Are you doing both here right now? Compared to what we're doing in fellowship?
When I was at NYU, Dr. Nitty he had just done the registration trials for Botox. So we did quite a bit of Botox in my training. And it was mostly because we were a referral center for neurogenic patients. We were seeing a lot of that patient population. And that is really the patient population that I think of when I think of bladder Botox. If you're a neurogenic diffuser overactivity, or you have diffuser overactivity with impaired contractility, that's the patient that I'm thinking bladder Botox for. So, I had an overwhelming experience of Botox. We did it both in the operating room and in the office, mostly in the office. When I went to Tampa, kind of shifted a little bit. They didn't like doing office-based procedures there so much, so I was doing most of my Botox in the operating room. And now I think I've shifted again. I like to do the women in the office, the guys in the OR, just for comfort.
Yeah, definitely, and I think that's the beauty of Botox. I mean, it's about doing it in the office, and that's the upside to it. Very low risk procedure. What's your ideal patient for Botox?
My ideal patient for Botox is the patient that's in urinary retention, because that's the patient that you don't really have to worry about side effects, right? Because when you're selling patients on Botox, you're having that discussion on Botox, you lose most of them when you start talking about urinary retention.
Exactly.
And, it's a discussion that you have to have, right, with your patients. So I think that patients select themselves for therapy, and they tend to deselect themselves for Botox once you start talking about retention of urine.
Are you doing 100 or 200, or what's your thought process when you decide what to use?
So for the neurogenic population, I start at 200 units. So if you're coming in with MS, a stroke, you have Parkinson's, you're getting 200 units. The diffuser overactivity, I'll start at 100 units, go up to 2. If 100 fails, I'll usually wait 3 months between injections. Have gone up to 300 units on some patients, off-label use, but can work. I've done it especially in the neurogenic patients. Patients can develop antibodies to Botox, and the Botox stops becoming as effective. And that's a tough patient population.
And these are patients that either have a suprapubic catheter, they self-catheterize, chronic catheter, they leak around it. That's what you're talking about, of those neurogenic patients that are having the bladder spasms.
And they do really well. If you have a patient that's wet and you could put them in retention and they'll be dry, they'll be grateful.
Yep. And I do have some patient of those. I started doing 100 because that's what I knew when I first started. But then definitely after talking to you, I started doing the 200s. Patient much better. I mean, they're dry. Like you say, they're dry, and they're pretty happy with it. What type of templates are you using? And is there a difference between templates?
So, when we trained with it, there was like, we did the umbrella thing, right? And I think when in my fellowship, we moved towards a grid template, and that's what I was very used to doing. Just half cc injections, depending on how much Botox you're using. And I just go, from UO to UO, up and down the posterior bladder wall, up to the dome and back. And then I always save a cc for the trigone. And I believe in injecting the trigone. If you believe that whole theory of the bladder contraction, I mean, it should involve the trigone as well. So we always injected the trigone. That last trigone shot can be a little challenging, but if you get it at the right angle, you'll get it in there.
And you will use that for both patients on retention or overactive bladder, or just?
I do, yeah. And it's just my mechanism. Now, there's been new studies that come out suggesting that you can do just like 4 or 5 injections of Botox in the bladder, just larger injections, and they've been successful as well. So, I question, does the template really matter? I think the issue is just getting the medication in there. What we were doing initially when we were doing the wheel, I think we weren't getting the medicine in the detrusor per se. So I think moving away from that wheel and just getting the needle in the muscle was really what changed.
And to your point, I have done a few patients that when you go for cystitis, I mean, they have overactive bladder. When you go in, half of the bladder is red. And those areas are very vascular, so you don't want to go, they start bleeding. So I have done 5-6 injections, put in all the 100 units, and they do good. They do good. I mean, maybe it doesn't last 6 months, but they're 2-3 months good.
And that's if you get 3 to 6 months efficacy on a Botox injection, I think you're doing well.
Are you doing for these patients with Botox? Are you scheduling every 6 months, or you're waiting for them to start having symptoms? How do you start doing it?
The first couple of injections are sort of a trial run until you figure out what that schedule is, and they will let you know. I have a lot of patients that are on a routine at this point, right? We know that every 4 to 6 months, we're going to do an injection. Some patients, it's once a year. Some patients can go 9 to 12 months with a Botox injection. Now that we have telehealth virtual visits, it makes it very easy. They just hop on, hey, doc, it's time for my Botox injection. I put the orders in for the procedure. They come in to get it done.
Are you doing it with a flexible, or do you have a rigid at the office?
So for the women,
yeah,
it's preferable to use a rigid scope. If you have it, it makes it very easy. We're using a flexible scope, and it's almost like a 2-person job when you're using a flexible scope.
Yeah, the ones that, I have the flexible. We have the same stuff. I think we have the Congenetics, which is pretty nice for diagnostic.
It's great for diagnostic. It's tough for procedures.
And definitely it is. I mean, it is a 2-man job. And definitely the MA has to, hey, inject, go ahead. Mm-hmm. So there's a learning curve in that part.
There is. And that's why, like the guys, I take them to the operating room because it's just so much easier to rigid scope them and be able to do it yourself.
Yeah. And I don't know about you, but doing a cystoscopy in the office, every time it's more challenging. I think people, I mean, at least guys are not as comfortable. I started doing some Valium for patients that when I say, hey, we're gonna what a cystoscopy is, I looked at their face, so I started doing a 5 milligram Valium to see if that helps. I haven't seen that much difference. The one's that's gonna scream is gonna scream.
I do Ativan 2 milligrams for a lot of my procedures. If the patient is very anxious, and I find it helps to some degree. Always, in the office, you're in a rush, you put that lidocaine jelly in, or you're really waiting 5 or 10 minutes for it to take effect, right? The tough patient's going to be a tough patient, right? No matter what you do. But there are things that you can do to minimize the misery in the office, right? And I think that those things are important.
So you're using 2 milligrams?
I'll do 2 milligrams of Ativan 1 hour before the procedure, right? For example, I try to not use it for things like PNEs because I like them to be able to give me the feedback then and there, but for a scope or something like that, bladder biopsy, something like that, no issues. Okay.
And are you doing, for example, a male patient that has some overactivity that also has BPH? How do you treat that? I mean, do you treat the BPH first and see what happens? Are you doing Botox at the same time that you're doing BPH treatment? I had a patient that I did urolift and Botox, and he went to retention. So we was catheterizing, and then 2 months after, he was doing good. So
it takes a couple of weeks for them to get out of that retention, right? And if they can get by with catheterizations, if they're doing CIC, they do very well. I tend to think of it as, it's the chicken or the egg phenomenon, what happened first. And, in my mind, it's the bladder outlet obstruction causes the detrusor hypertrophy and the overactivity, right? And I always focus on treating the outlet first. And then we go from there. It's easy to medically manage, right? So I don't have any issues. I don't like to do shotgun therapy, so I'm not going to start a guy on tamsulosin and mirabegron at the same time. But I'll stagger it by 2 weeks, and we'll see how we're doing. And if he's not better at that point, then I typically will scope him, get a urodynamic test. If they got mixed symptoms, right? Figure out, is the obstruction really a problem? Is the bladder still squeezing, right? And then typically go after the outlet. If the overactive symptoms don't settle down after you go after the outlet, then I'll go after the OAB pathway. And those are the patients that I try to avoid things like doing green lights on. I find that if you have retention but irritative voiding symptoms, those patients don't do well postoperatively with green lights. It really makes the irritative symptoms bad.
They're miserable for 3 months, and really, maybe Mebetric works. I'm trying the gem test, but definitely, I do a lot of green lights, and patients that do have overactivity, after I do the green light, the flow is good, but they're going to the hour every hour on the hour,
and they're miserable.
Yeah. So but eventually they do good. But those first
eventually, but I tell them at the bare minimum 6 weeks of, if they're insistent on getting a green light or they're on an anticoagulant and we have to do a green light, I tell them it's going to be a bare minimum of 6 weeks of burning with urination, and you're not going to be happy with the urinary symptoms before things get better. So, it's all about setting expectations too.
Yeah, exactly. So I don't know, maybe Resumum works better for those patients. I don't know. I'm going to try to start doing other stuff there. So Danny, let's talk about the male patient again and the overactivity. When you do the Botox first, let's say you look into do the cystoscopy, you do the urodynamics, not much that obstruction, you do the Botox, and now he has slow stream, but he's emptying completely. Do you wait until the Botox is gone to assess? Because you don't know that if it's the obstructive part now or what is the Botox. How do you deal with that patient?
So when I do Botox first, I try to wait 3 months before I make a judgment call on a secondary procedure.
Okay.
Because that really allows the Botox time to declare itself. In theory, Botox takes 7 days to reach maximum efficacy. But if you're having mixed symptoms like retention, it can take up to 3 months to really wean off. So if I'm going to flip therapies, like go from Botox to sacral neuromodulation, I'll wait 3 months before I go down that pathway.
Okay.
But with the BPH guys, right, it's tough if they're not emptying their bladder, right? So I always try to push CIC as much as I can, but if they're catheter dependent and they're miserable and they really want the outlet reduction, well, you go after it.
I don't know in your clinic, but I'm seeing more patients that have irritative symptoms, overactivity, versus the classic, hey, I can't pee. I don't know if it's if that's what you're seeing also, but
I see a lot of overactive bladder just because of the nature of my practice. So I would agree with that sentiment. I see a lot of guys with irritative voiding symptoms that are not obstructed. A lot of them have bad diabetes or
exactly
other comorbidities that lead to overactive bladder, like they're on multiple diuretics or things like that. And you have to manage those symptoms because they need to manage their comorbidities.
And it takes time to convince them that it's not the prostate. I think that's the strong, the difficult part is convince them that it's not the prostate.
But that's where I go to diagnostic testing, right? If these guys aren't getting better on alpha blockers, I don't hesitate to pull the trigger on doing a urodynamic test or a scope, because it really, it's in the guidelines, it's in the algorithm, and it's indicated, and it gives you the information that you need to move forward to therapy. And I really push it on my guys that are 65 or older. The incidence of the choose your underactivity can be very high. So you don't know if these guys are having impaired contractility versus overactivity or obstruction. So it could be very telling.
Danny, so let's talk about neurostimulators. So for the overactivity or voiding dysfunction, those are, Botox and neurostimulator are the tools that one use. Are you using Medtronics, Axonics? You use both? Any difference?
I use both. So, we could go down the rabbit hole of constant current, direct current. That's not a conversation that I think is within our scope. I think that as long as the energy is being delivered and you put the lead in the right place, the therapies are relatively equivalent. I've found that, not everyone is a candidate for a rechargeable device, right? And Axonics still has the only primary cell on the market.
You found that the hard way?
Yeah,
I did. So
it's true though. You have to think about that because you don't want to put the burden of recharging on the caretaker. And if that does become a burden, they're not going to recharge it. They're not going to get their therapy, and that patient go with a battery operated device.
yeah, because definitely, I mean, one thing, the control is much easier on the axonics for someone that might not be so savvy with the Medtronics one, but then that person might not be able to recharge it as well. So it's
Correct.
I mean, yeah, so it's a catch-22 in that sense. So who's your ideal candidate for a neurostimulator versus Botox, for example?
Well, again, I like the patients in retention for neurostimulation. I think the patients in non-obstructive retention do really well. But for me, again, it's all about what the patient wants. And once you start talking about neurostimulation and how it works, most patients tend to select that pathway. I think that, when you talk about a staged approach where you can actually take the therapy out on a test drive and get a sense of whether it works for you or not before you have to make a commitment to that therapy, I think a lot of people buy into that. And at least in my practice, I do a lot of percutaneous nerve evaluations. So, you come in, it's a 15 to 20 minute procedure. You wear the device for 3 to 5 days, and then you can make a decision as to whether that's right for you or not. And if it's not right for you, then we can talk about Botox or tibial nerve modulation. But I think, tibial nerve modulation, sacral neuromodulation, right, are flip sides of the same coin.
So for a patient that has Foley catheter, and are you doing P&E or you're doing a stage 1 for those patients?
If they're catheter dependent, we have to get them out of that state. So I learned that one the hard way too. You either need to put a suprapubic tube in them or you need to teach them CIC. If they're in retention, I'll go in, and they refuse to learn catheterization, I'll put a suprapubic tube in, and then I'll do a staged approach.
Okay.
For that patient in particular. Because when they're in chronic retention like that, it takes them a little longer for the bladder to get going. It's not going to be that 3 to 5 day P&E that's going to jumpstart their bladder. So for that patient, a staged approach is often a little better. But for your frequency, urgency, and I don't know if you see it in your practice, but my overactive bladder patients, even more so, they're coming younger and younger. And those patients do really well with neuromodulation because it's they understand that it's a device, it's something they can control, it's something they can recharge, and it puts them in the driver's seat of their symptoms.
And in terms of let's talk about some complications of the devices. I mean, some patients complain of chronic pain down the leg. Do you try to replace it? What do you do with those patients?
If they're having pain down the leg, first thing I do is reprogram. I try to get the arc of the energy as far away from S4 as possible. So you try to bring it up closer to S3. And, usually if you're getting referred pain down the leg, it's because you're getting closer to 4. The patient that doesn't do well with a reprogramming, then I would consider a lead revision. And I'm not hesitant to do a lead revision on a patient. I think that the patient that has pain at the stimulator site can be a little bit more challenging. Sometimes you have to do battery revisions or, generator revisions, get it a little deeper if it's too superficial. I like to really stick to the 2 centimeters. So I take the long end of an Army Navy. It's actually 3 centimeters. So I tend to check my pocket depth a lot with that. And it's a good little trick to make sure that you're like in the right plane. And just using that long end of the Army Navy gives you like that right depth of penetration.
That's for both?
For both, right? The micro or the rechargeable device.
You use the same depth?
They're both supposed to be approximately 2 centimeters from the skin site so they can communicate to the connector device.
Okay.
So I use the same depth. But for the rechargeable device, I like that technique where you take the Army Navy and you just make your pocket with the back end of the Army Navy and you just slip the battery underneath that.
Exactly. So that's what I'm doing for the Axonics one. Have you used the rechargeable of the Medtronics, of the Intersteam?
I have. And I've had some patients come in with dead primary cells and they want to upgrade to a rechargeable device or an MRI compatible device, and they want to stick with Medtronic, and we absolutely go down that pathway.
You don't need to change the lead, right? I mean, as long as the lead was MRI compatible.
That's the catch, right? So the primary cells were the things that were not MRI compatible. The lead was MRI compatible, but the lead is not interchangeable. So if you're going to go from primary cell to rechargeability, you've got to do a full swap. If you're just going to put in a MRI compliant primary cell, you can keep the same lead.
So I think that was like 3 weeks ago before all this COVID stuff that we cannot do surgery started.
Yeah, it's tough.
I did a patient that she has in IC, and over at University of Michigan, they put two devices, two intersteams.
Yep, I've
But
heard of that.
somebody else had already placed one, so she had 3 leads and two devices. So I was able to remove the batteries with the leads, but the other lead, the original one that was like 15 years ago, it broke. So
It's tough.
so it stayed down there. I mean, I sent her to a neurosurgeon. What's the next step with that?
So, I mean, the package insert says leave it alone, right? If you have a fractured lead, you don't go after it. That being said, when I was in my fellowship, we did do some aggressive manipulations to try to extract leads in patients that needed to get MRIs. And, we have done, you can't do it in conjunction with neurosurgery if you just completely lose the lead inside the foramen, because at that point you're really digging in a space that's not familiar to most urologists.
Yeah, because I mean, I dig down, but on the C-arm, the lead that fracture was anterior to the sacrum. So I say, hey, there's no way I'm getting there. So
Yeah, that's tough.
yeah,
That's a tough
so I
space.
sent her to because definitely that person, she needs an MRI for other reasons. So she's gonna have to get that lead removed. I guess that tip
Yep.
of the lead.
And that more than likely, and I mean, I think the spine guys are much more comfortable in that space than we are, and it's definitely not wrong to get them involved.
Yeah, Danny, and you mentioned the PNEs. So you're doing PNEs, and then if it works, going straight to the full implant.
Correct. And a lot of people have the facility of fluoro in the office. I don't, and I'm doing blind P&Es in the office, and I do really well with them. My conversion rate's in the mid-90s. So I think that if you're doing good technique and you just spend a minute or two to get the needle in the right place, you'll have good results.
Yeah, I think that there's some group that or there's I don't know who brings the C-arm to the office, but one of the guys from the group are doing that also.
We have that option. I think there's a third-party vendor that will bring fluoroscopy into your office.
Does it make a difference in terms of the billing for us in the RVU model? Does it matter?
For us in the RVU model, it does not matter. So for the office urologist, perhaps he can bill the fluoroscopy with interpretation of images up to 1 hour, but at the cost of getting that C-arm in the office, right? What I can tell you is that in my fellowship, we had a C-arm in the office. We used it a lot, right? Not just for PNEs, but for video urodynamics, and we did rugs and cystograms, and every, catheter that needed to be pulled was studied before. But when we were doing our PNEs, we always marked the patient as if we were doing a blind PNE. And 9 out of 10 times we would go with our markings when we were using the C-arm. So I found in my practice that doing blind PNEs works very well.
And definitely, I mean, you can bill for that and then bill for the full implant. So the revenue is better.
Yeah, and I like to stack them. So I'll do 2 PNEs on a Wednesday afternoon. So, I'll block my schedule after like 2:30 or 3 o'clock, and it's just an easy afternoon for me, and a relatively profitable afternoon.
So you do them on Wednesdays, and then you will see them again on Monday, or just have the patient call to the office and go straight to the OR? How do you do that?
So they'll come in on Monday or Tuesday for the lead pull. And, if I'm in the office, I'll see them. Sometimes I'm in the operating room and my nurse will just take out the lead. And if they, we'll set up a virtual to go over the diaries if we need to, and we'll book the procedure.
And does you're always in conjunction with the rep?
Yeah. With neuromodulation, you have to work with your rep. I don't fight with my reps. I listen to my reps.
Yeah.
They're there to help you, and I think they make a huge difference, right? A good rep can make or break a case, and I think a lot of the hard work with neuromodulation gets done after the fact, right? The implants, what we have to take care of, but reprogramming, troubleshooting, that's where the finesse comes in with this procedure.
Exactly. And if you have to do a stage 1 and then a stage 2, how long do you wait? A week, 2 weeks?
So you can go up to 14 days. Let's say I do a PNE that doesn't do well, but still wants to move forward with the staged approach. I'll tell them we can do a 7 to 14 day trial, and we'll do a stage approach. And I always plan for 7 days, but we touch base halfway through the trial. And if they're not doing well, we'll extend. So typically these procedures are, once you're doing the staged approach, the stage 2 is really a 15 to 20 minute operation. So it's not really too off-putting if you've got to stack an extra case next week to give the guy or gal an extra couple of days with the trial.
And for a patient with obstructive retention, for non-obstructive retention, does it changes? Or would you place the full implant and then let it wait a couple of months and see how it goes?
So if I have any improvement in the non-obstructive urinary retention patient, I'll push them towards an implant. And I find that those patients start to do really well at about 30 days. So it takes the nerve, I think, a little longer to learn the message, right, in these retention patients. Probably just the mechanism of injury is different. If they see, for example, I tell them a success would be going from being in retention to voiding spontaneously throughout the day and then needing a catheterization before you go to bed. So that for me is a very successful trial.
Definitely.
And that's the type of patient that I'm really pushing for an implant.
And you will go straight into the implant, right?
Well, if we're staging it, no. It's P&Es with the retention patients, I've done them and they do well. We go for an implant. If they don't do well, we'll stage it.
You will still stage it. Okay.
If they don't do well with the P&E.
Yeah. I staged those, but again, at the end, like you said, it's 30 days. So you do the full implant anyways, without them getting better, and eventually they will get better.
It's true though. You see it at about a month.
Yeah. Some of that you get lucky and they start voiding 5 days with the stage 1, but yeah. So Danny, in terms of let's say if you try to change the entire implant, let's say a patient wants to, the battery is like an old intersteam, the battery is getting dead, mm-hmm. and they have great results. Do you just change the battery or do you ask them, hey, do you need an MRI, or would just try to push them to change everything?
I firmly believe in shared decision-making. So yeah. I put it up to the patient, what do you want, right? Do you want the new MRI compatible device? Are you happy with your current therapy? And do you just want your battery swapped out? So I never push therapy. I think that's a recipe for disaster, right? So whatever the patient wants.
Okay.
Now what's my threshold? I typically tell patients if, let's say you're going in for a revision or some sort of issue, if anything's older than 18 months, we might as well just do a full swap out. Once you start to hit that 2-year mark, might as well just take everything out and swap it out.
Exactly. If they're having other issues. Okay.
If they're having other issues.
Okay, Danny, anything else, any takeaway or anything you want to mention in terms of Botox or neurostimulator therapy?
I think that you shouldn't underestimate the patient with fecal incontinence for sacral neuromodulation. When I started my practice here and in Tampa, I would say the number one indication that I was doing it for was fecal incontinence, simply because I query my patients for fecal incontinence. It's part of my talk track at this point. So, everybody gets asked if they have fecal incontinence, and not only does it work very well, but they are very grateful patients. And those are some of the happiest patients that I have in my clinic. Because if you go from having fecal incontinence to no fecal incontinence, that's a real game changer in your quality of life, right?
Definitely. And I have patients that for urine doesn't work. I mean, they still have overactivity, but they don't have the fecal incontinence, and they're happy.
They're happy.
And
they're absolutely
I think the first time that happened, I didn't even ask if they're having diarrhea, or incontinence, and say, well, it's not working enough, but I'm happy because I'm not having any fecal incontinence. Well, I didn't know you had it. But yeah. So after that first patient, I definitely talk about that also. So Danny, I wanted also, something new that we both of us are doing, the bulking agent. I wanted to talk about this. And definitely, did you do any coaptide before or any bulking agent before the Bulkamid?
A little experience with Durasphere and macroplastique, but mostly coaptide. We did most of our coaptide in the office with the Wolf scope using the Sidekick needle. And, at NYU, all we did was lidocaine jelly, and you go with your scope and you got your injection. The whole procedure may take 2 to 3 minutes, right? It's a relatively quick procedure. I didn't love the results with the bulking agents. My big issue with the coaptide was the minute you withdraw the needle, you start to see the coaptide coming out of the injections. And, I just questioned the longevity of the agent. And that's why most of those patients, you counsel them that they're going to need a touch-up, repeat injection to get them dry. If they're ever catheterized, their continence is going to go away, right? I think that that's changed a little bit with the new bulking agent, the Bulkamid. I've been having some very good results with that bulking agent. I think what was most impressive for me is that when you inject that gel and you withdraw the needle, there's nothing coming out. That gel is staying in place. We're in the same situation right now where, unfortunately, because of COVID, our hospitals are in black status, so we're not able to do any elective surgeries. So I've been counseling a lot of my women to try bulking agents. And I've done quite a few injections in the office, and they've all done really well. It's a quick procedure. It's minimal downtime. I tell them you have to take it easy the day of the injection, and the next day, normal routine. If you're doing CrossFit, go back to doing CrossFit and tell me if you leak urine. I had one patient that couldn't void post-operatively. I've done a handful so far. And we just did a quick in and out catheterization, sent her home, and she was fine.
You use a 12 French or?
So I use the 12 French, just I like the Coloplast Compact just because it's a very small catheter and just in and out, boom.
And you're using intravesical anesthesia, or you're using Urojet?
I will do a Urojet, and then we'll take some of that Urojet, smear it on the labia so that it gets some periurethral analgesia topically. And then I'll do a periurethral block, just 3 to 5 cc's at 5 and 7 o'clock. And some people have been putting bicarbonate into the lidocaine. It does help somewhat with the irritation when you give the injection. I will also give that patient Ativan 2 milligrams prior to the procedure. And we're using the Bulkamid, the mini scope, which I think also it kind of revolutionized the way that you administer the bulking agent, right? So the technique has changed a lot. It's no longer that injection where you're skiving in and trying to inject the agent laterally. You're more creating a cushion circumferentially around the urethra. So also good results.
And Danny, I forgot to ask you for Botox. What do you use for anesthesia?
Just Urojet, just a Urojet.
So you're not using intravesical anesthesia, with like 30 mLs or some lidocaine watch?
No,
just the Urojet.
Not typically, just the Urojet. But again, I find that women tolerate things much better than men do in the office.
Definitely,
right?
definitely.
A guy, I wouldn't do that to in the office.
So Danny, Bulkamid, do you think, are you gonna do more Bulkamid rather than slings? Or do you think you're gonna replace the patients instead of using slings, or are you gonna actually have patients that didn't want a sling, you're gonna do this more?
I think it's an easy conversation starter. It's a quick office-based procedure, and downtime is maybe one day where you're back to normal activity the next day, versus doing a sling where you have to tell the patient, it's going to be 3 weeks of no heavy physical activity. You've got to let that thing score into place. If not, it's not going to work as well. And given our current situation with our limitations of operating in the OR, it's gravitated my counseling towards that. And I've found that patients are doing really well with it. I can tell you anecdotally, some of the guys that have been doing this a little longer than I have been doing a whole bunch of it. And it's a much easier talking track with the patient, right, towards an injection versus a procedure in the OR.
And definitely, virtually zero side effects. Like you mentioned, if you cannot urinate, you can remodel the blob that you created, and that's it. So it's very, very interesting. Definitely, I think a game changer, something easier in the office that you can do for a long time. It supposedly lasts 70 years. We'll see if that's true. But yeah, for now, it sounds pretty good.
And it's allowing us to keep treating patients, which is what the most important part.
Exactly. So Danny, I think it's time to wrap it up. Thanks for being part of the show.
Thanks for having me.
Yeah, no. I will definitely continue to talk, and we'll talk about more avoiding dysfunction in men, because it is a big topic, and we can also be there talking a full show. So thanks again for being here. Take care. Good night, man.
Thanks, and you guys have a good night as well.